This is an interesting trial of patients for patients with primary or post-myeloproliferative disease myelofibrosis, in whom initial JAK inhibitor monotherapy has not been effective. This is based on a trial of the new drug, Zelavespib, which is a purine scaffold epichaperome inhibitor. It selectively binds to the epichaperome complexes found in cancer cells by an altered ATP binding site of the disease-associated heat shock protein HSP90. Patients with primary or secondary myelofibrosis who had a reasonable performance status and have received at least 3 months or more of Ruxolitinib, but have persistent or worsening splenomegaly and disease-related symptoms, were eligible for treatment. Of course, patients had to have no evidence of cardiac, hepatic, or renal dysfunction and have an adequate platelet count defined as 25,000 or above and a neutrophil count of 500 or above. They were given an oral solution of this disease-associated heat shock protein inhibitor that was administered in 11 patients at different dose cohorts in a 3x3 type of design. The median age was 69. The baseline Ruxolitinib dose ranged from 5 to 25 milligrams twice daily, but the median was 15 milligrams. The median number of cycles of Zelavespib was 4. There were some grade 1 and grade 2 adverse events that included abdominal pain, diarrhea, and fatigue. 2 patients out of these 11 had grade 4 thrombocytopenia with DLT criteria met, with nadir platelet counts of 7 and 22,000. 1 patient developed grade 3 bone marrow hypoplasia, although this patient achieved quite a bit of symptomatic improvement. And that hypoplasia was after 22 cycles of treatment, an SAE judged by us and the investigators to be treatment related. 2 patients demonstrated symptom improvement without significant reduction in spleen size. 1 patient at a 50 milligram dose had stable disease maintained for 20 cycles and was bridged to allogeneic transplant. So this drug directed against heat shock protein 90 at doses of about 100 milligrams a day was well tolerated and has been selected for the randomized phase 2 trial in combination with Ruxolitinib. Although the drug alone has not been shown to cause myelosuppression, we need to further evaluate whether there is myelosuppression accumulated over a long time when the investigational product is used in combination with Ruxolitinib. The study does show that there is a therapeutic potential of this oral drug, oral Zel, in the treatment of myelofibrosis, not responsive to Ruxolitinib when given in combination, and that will be the phase 3 trial.